The following is a recorded program of an actual stroke support group. The comments expressed are the personal opinions of the participants and not necessarily the opinions of the producers, sponsors, or the broadcasters of this show. This program is not to be used as a way to diagnose or treat any medical condition that you may have. Please consult your doctor or healthcare professional before making any changes to your current medical routine.
Stroke.
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 It comes out of the blue, sometimes without warning.
But those who survive it
should never lose hope.
A stroke can be life-changing.
But it is also
A new beginning.
because for all survivors, there is still a beautiful life after stroke.
Hey everybody, I'm Christopher Ewing. Welcome to Life After Stroke. And today we are broadcasting from our new location. You know, as many of you know, we take a support group and we, as I say, put it on steroids. We record it, and what happens, happens. Whatever happens here doesn't necessarily stay here. It gets broadcast and gets sent all around the world. But we are at our new location. We are broadcasting from Providence St. Joseph's Medical Center in Burbank, California. And we have a bunch of shout outs and a lot of thank yous to give, not the least of which goes to Dr. Rob Darflinger down at the end of our table here, who was really instrumental in being able to arrange for this new location that we're at. Not that we didn't like the old location, but being at this location gives us an opportunity to have access to just all kinds of great professionals in the medical field right at our fingertips. I mean, rather than asking them to jump in the car and leave their hospital or office to come and be a part of the group, now they can just get on the elevator and push one and come on down and see us, and they can go right on back up to wherever they got to go. And on this episode, we are really fortunate to have an outstanding doctor with us, as well as other people that are here. We are very fortunate to have Dr. Ambooj Tiwari with us today, and he'll say hi in a moment and tell you all of his great credentials and all the wonderful things that he's done, because, man, there's a list of them. I'm reading his bio, and it's like, oh, my goodness. And you look so young, man. You've done so much stuff. My goodness. Would you start when you were a baby?
Pretty much.
Yeah. Okay.
My mom's a physicist, so she didn't let me off easy.
There you go.
Kind of like your mother.
Like my mom, exactly. Yeah. When, you know, my mom started college at 15. She got triple promoted through school, and I graduated high school early, but not that early. But but also we are also blessed to have the presence of other stroke survivors that are here. As I said, this is a stroke support group, and so therefore we've got stroke survivors in here that are going to give a shout out now and say hi to all of you and stuff like that. And so we'll start to my right and go around the horn.
My name is Dave Caldwell. I had a massive right frontal stroke about 2 years ago.
And earlier, before we went on the air, Dave, and we're going to talk about it more, you really have just so significantly improved. It's just amazing. It is really, and this, your stroke was how long ago? Just 2016?
Yeah, 2016, November.
Wow. And tell everyone a little bit about the deficit that you had following your stroke.
I was paralyzed in my left side, completely, left leg, left arm. I learned how to walk again in about 2 weeks. The people here were actually relentless in helping me work. I had two nurses that came to my bed every morning and said, "Today's the day, you ready?" Would bring me a pair of my tennis shoes, and we would walk. Mm-hmm. Then I would walk upstairs and downstairs, and there's a stairway in the behind the hospital, and I went up and down that stairway probably 30 or 40 times each day.
Amazing.
To learn how to walk again. And then they caught me walking at night. I would put my shoes up, and I would walk the hallways at night. Yeah. Once I could walk, I didn't want to stop. I was afraid something was going to happen if I didn't keep walking.
Absolutely.
So I got caught walking the hallways at night. I wouldn't recommend it because basically they said if you fall, it's going to be another couple weeks in the hospital.
Yeah, that's true. Yeah.
So don't just go out and start walking. Make sure you have support.
Sure. Dave, it really is, everybody listening, you know, and the plan is to put this on video, eventually do our support groups on video, but doing them audio-wise right now. But if you could see the dexterity that he has, it's amazing to think that you were ever paralyzed at all, because you just are just
Well, I moved on to water aerobics, Tai Chi, and yoga.
Right. Now, that's what you had mentioned that earlier before we went on the air, and I wanted to ask you, of those three, which do you think was the most beneficial towards...
Probably Tai Chi and yoga.
Really?
Yeah.
Okay. Why do you say that?
Just because basically it's basically a choreographed dance, and you just have to get all the moves down. And then yoga, people are extremely supportive, you know, once they find out, because I couldn't lift my hand up.
That's amazing. He's got his arm straight in the air, and you guys, and his fingers are great.
My fingers now. I can actually hold coffee in my left hand.
So now, how much following your stroke was it before you got that kind of return?
Probably about a year. I mean, I can walk up here with coffee now, and I've just started doing that. But I've got 7-year-old twins also. They were a big help.
Gotcha.
They were 5 then. I mean, and now I walk them to. Walk one to taekwondo, then the other one I walk to her gymnastics class.
Wow.
And I pick them up from school also.
Oh, that's awesome.
It's a big change.
Sure. Wow. That's awesome. So awesome. Congratulations to you, Dave. Absolutely. We'll go around the horn, and while it's going around the table, it's going to stop at Dr. Rob Darflinger. And so,
Hey, Chris. Thanks for having me again, and I'm really happy that we're able to start this at this facility. I hope it works out, and I'm just really happy that we have so many great partners and everybody involved with this that are helping out with this.
Well, I told you, you're stuck with me. Ain't nothing you can do about it now, brother. Nothing you can do now, Doc. You got to be careful what you ask for, because I might just listen and do it. But really, I can't say enough, man. You have just been awesome, Doc, and I just really thank you for just helping put all this together and facilitate everything. And I could go on and on just about you, man. You're just awesome. And as I've said before, not only do I thank you for this, but I thank you for what you've dedicated your life to. You're helping people live again and bringing life back to people and families. And like I said, man, you could have been anything, but you chose to be a doctor and a lifesaver, and I'm just proud to have you as part of the show. So thank you so much.
Well, you're very welcome. That's very nice of you. I'm happy to be part of it. Thank you.
Hi, my name is Helen. I had a stroke in July of 2013.
Nice to meet you, Miss Helen. And sitting next to you is?
She's my daughter.
She's your daughter.
Hello, I'm her daughter. I'm Wanda.
Nice to meet you, Wanda. And Miss Helen, when you had your stroke, what were some of the deficits that you had following your stroke?
Just slower talking. I had not a little movement, but a delay in standing up, and so on and so forth. And I still feel like I want to run, and I can't. I have problems going up not up the stairs, but down the stairs.
Because of balance or just dexterity, or?
I think more so balance.
I understand that. My balance is a mess, so I totally understand that. Absolutely. Well, it's really nice to have you here, Miss Helen, and your daughter as well. Thank you very much.
Thank you.
I'm Bob Parker, and I do Tai Chi as well.
Yes, you do. Well, you do a lot of things besides just Tai Chi. I mean, let's to kind of add a little fine print to this. This is Professor and Dr. Rob Parker, and who has written several books.
Well, I've written 3 books after my stroke.
Right. And you've written several prior to that, but now you're the ones that more specifically about this topic. Talk a little bit about those.
Well, the first one was I am on my way to healing 2 strokes and a recovery. That's a book about my strokes.
And a little bit about your background, Professor, is that you're a professor at Rutgers for, 25 years, I think you said?
Well, I've taught at the University of Chicago, taught at Rutgers University for 20 years, and taught at the University of Dufferin, California. That's where I had my strokes.
Yeah, I think you had mentioned you were going out for coffee or something, and you actually had it in the parking lot. Is that right?
Yes, I was going out for some coffee, and I just pulled into the parking lot and had my blinding flash. That was the first stroke. That was 10 o'clock in the morning. My second stroke occurred 4 a.m. Now, the second stroke, Joe Massoli didn't think I would come out of the second stroke. Jen, my daughter, didn't think I would come out of the second stroke.
Now, when you had the first stroke in the parking lot, did you go directly to the hospital?
Yes.
And so you had the second one in the hospital? Amazing. And talk a little bit about the deficits that you had immediately following, because you've had an amazing recovery as well.
Yes. I was flat on my back. I couldn't walk. I couldn't talk at all. I couldn't move my arm. I had my right arm in a sling.
Amazing. And again, everybody, if you see him now, I mean, he walks in here, he is, everything's moving and working, and he's talking. And I can only imagine, as an educator, as a professor who's spoken and lectured countless times, just how tough that was probably to not be able to talk. I mean, because you could think quite clearly, right? Obviously.
I could think, but not talk.
And what helped you with your recovery of the ability to talk?
I am still making progress.
Sure.
And I don't think it will be over until I die.
Well, that's what the doctors say. All joking aside, I've heard doctors, that have refuted that whole 3 month, 6 month, 1 year, that's your new normal, that's all you're going to get kind of thing, where they say you'll continue to improve until you die. And so, absolutely.
Right.
Absolutely. When did your speech start to come back following the stroke?
Well, Amy Bowman, who was the speech pathologist in Huntington, I had a lesson from Amy, and I said the next week, I said I could. The next week, I said I could not.
And that's when she hit you and said, yes, you can, right?
I couldn't finish any of the sentences.
Wow. So it's just amazing that, just the recovery that goes on when you see this type of thing. It's just so amazing to me. And we'll get into more about your books and things like that, which are available on Amazon. And I just think that's fabulous. What were you going to say, sweetie?
I was saying it's amazing. I mean, given that you've survived not only one stroke, but 3 strokes and written books.
Yes. Isn't it amazing?
It's amazing.
It is amazing, isn't
I know. It's amazing to me.
I bet.
Absolutely. And we're going to have links on the strokechannel.tv website where you can, get the books and things like that. So you'll be able to click on there, and they're available on Amazon. And so I encourage everybody to go in there and search and explore and stuff like that. We have gone around the table and have wound up to our featured guest here. This is Dr. Ambooj Tiwari, and Doctor, thank you so much for being with us today.
Thanks for having me, Chris.
You have such an incredible list of accomplishments in your young career, I'll say, because you look like you're a baby. And but so I'm just going to let you brag on yourself for a few. Tell everyone a little bit about what you've been doing and things like that.
So I'm an interventional neuroradiologist or neurointerventionalist, as some people say. I come from a neurology background, so I did stroke and critical care neurology prior to training in neurointerventional surgery. Most of my training was done in technically you're in my hometown, Detroit, Michigan. And I was there for 7 years, training through residency and all my fellowships. Prior to that, I did a degree in biostatistics and epidemiology out of University of Massachusetts, and before that I was at University of Delhi in India, where I did my med school. For the last 4.5 years, I've worked at NYU in New York City. I was at the Brooklyn campus. That was my first job, and now I just started here recently. Published a lot on different modalities in stroke, different kind of issues. I'm very passionate about it. I got into this field because of family history. A lot of us get into these kind of things because of family history. So.
Right, and I know that's one of the things we're going to talk about. And I will just kind of put him on blast over here. Dr. Darflinger just raves about you, and I've had the pleasure of meeting you now for the second time today, and I'm just so thrilled to have you. So I just really appreciate you being here. Before we kind of get going here, I want to give a shout out to a woman who she attends support groups that I attend in other places, and a couple days ago, actually just yesterday, got an email that she had just had a second stroke, and I won't mention her name. She knows who she is, and if she's listening, just know that I'm praying for you, sweetie. And I guess my question, besides telling everybody, hey, send some prayers up for her, and again, I won't mention her name, just kind of say I'm praying for whoever Christopher's talking about. But on the subject of second strokes, I guess I kind of want to go here. I have heard that once you have a stroke, you're more susceptible to having a second stroke. Is that correct?
Right. So most of the data which we know from stroke, you have about 800,000 strokes in the country every year, and about 25% of them are repeat strokes. And from an individual level, if you've had one stroke, then your chances of having a second stroke is 40% in the next 5 years. So your chances do increase, and there's some situations where it increases significantly, in some cases not so much.
And why is that?
Well, for most parts, I think one of the worst things about the first stroke is stroke is a marker of what we call vascular risk factors, which means that your arteries are not behaving as normally as they should. And once you have an event like a stroke, you sort of get on the fast track of worsening of your arteries.
I see.
And it's some form of inflammation, so to speak. So you would also see that once you actually look at stroke per se, or even mini stroke like TIAs, people who get better quickly, over the years, a lot of research has shown that this contributes to not only more strokes, but also more heart attacks, more dementia, and more other problems. And it's just a general profile of how all your arteries are behaving. Some part of it has to do with people not taking care of themselves enough, because you're not able to move, you're not able to do things.
I see.
But a lot of it also has to do with just not enough education. You got to manage your diabetes better, your blood pressure better. If you have AFib, you got to completely be certain that you take your medication, irrespective of what a lot of people say.
Yeah, so that was going to be my next question is that, for those of us who have already had one stroke, what can we do to kind of help our chances of not having a second one? Is there something that we should immediately start implementing into our diet, into our lifestyle, getting out of our lifestyle, getting rid of out of our diet?
Right. So most people who have their first stroke typically, unless they have had other problems, but looking at this room, they've had risk factors for the first stroke, and they sort of know what the risk factors were. Most of those risk factors are modifiable. Your blood pressure needs to be 100% under control. Your diabetes, honestly, a lot of people don't realize, but diabetes is what really makes your arteries really go bad very quickly. And the biggest killer out there, which a lot of people don't realize, is smoking and alcohol. And people say that you quit smoking 2 years later, you're back to where you were, but the reality is that's only for your lungs. It's not for your arteries. So you have to I mean, I have stroke patients and aneurysm patients, a young mother, 28-year-old, who I kept on insisting for 4 years until her aneurysm ruptured again. We were able to save her, but the idea is that, it's a really, really bad habit, and people have to work on it. And even the first cigarette after a stroke is poisonous. Same with alcohol. Alcohol intake has been associated significantly with worsening outcomes.
All right, everybody listening. So look, I was just about to say we're going to take a break, but this doesn't mean that we take a break and you go have a cigarette or go have a drink. Okay, that's number one. Definitely take those words to heart. We have so much to go over on this show. That's why we're taking our break now, because we just have a list of stuff to go over. Before we went on the air, you talked about some totally amazing stuff, like delayed strokes. And I mean strokes that were delayed by weeks and months and years, and just all kinds of amazing stuff that I can't wait for you to really share and delve into and things like that. We're also going to talk about the risks of going to a chiropractor. You had mentioned that you've seen a number of people come from a chiropractic appointment, and you've seen them wheeled in here with a stroke as a result of it, and I want you to talk a little bit about that. We're also going to talk about stroke in young people, family histories of stroke, obviously the incidence of repeat strokes, and a whole lot more. So everybody sit tight, and we'll be right back. Hey everybody, welcome back to the show. This is Life After Stroke. I'm Christopher Ewing, and we are at our new location and very proud to be here. We are at Providence St. Joseph's Medical Center in Burbank, California. And one of the people here at the table, Miss Wanda, you had a comment.
I am just taken aback by how, like my mom has had her first stroke, like the percentage of having a recurring stroke is so high. I mean, this life event has just been, it's just been like tremendous. It's changed everything. My mother was never sick, always healthy, walking, climbing, everything my entire life. She was retired, and I actually was sick with a chronic condition with Stevens-Johnson syndrome and almost died. Had a 30% chance to live. This woman was pushing me in a wheelchair. So for my mom to have the stroke and have survived it, and now we're talking about possible reoccurrence. I'm frightened.
It's on a lot of people's minds.
I don't know what to say.
Sure.
Right, and one of the things I would say is that some of the data we're coding is from about 5 to 10 years ago. There has been a lot of progress in terms of understanding the processes, and there's a lot of like typical things to do that previously were not attended to as much. Part of the reason could be because stroke itself, the field of stroke has undergone a sort of a revolution in the last 5 years, and what has happened is that now that we can put people back to being almost completely normal, we're now working really hard to make sure that the second event doesn't happen, and a lot of work we do now in terms of outreach and stuff like that is to get information out there that you need to know that it's not a one and done situation. You have to get on top of things, and you have to get moving, and you have to make sure that you've taken care of your risk factors, and you've taken care of your AFib, and you've attended to all these questions, and this information's out there on forums like these, but also like if you just type recurrent stroke, you would come across CDC's website or American Heart Association's website, where it goes through all the things that you can do
to guard against having a potential second stroke.
Right. The important thing I would say is that if you had what we consider a freak stroke, then the chances of having a second one is very low. But if you have a typical risk factor related stroke, then your chances are higher.
So a freak stroke is like, well, what brought that on? I don't know. But versus the one where you knew your blood pressure was 300 over 1,000,000 and you had no business doing this, that, and the other.
Right. Okay. So the chances of fixing the percentage of strokes which can repeat themselves is way higher because you already know why you had the first stroke and you cannot go the same way. And people do lose some ability to get around, but there's a lot of activities that have been developed to.
Are there any numbers on stroke in terms of what are considered freak strokes versus ones that are strokes that happen because of knowledgeable reasons, I guess you'd say, or something?
So interestingly, I'm going to go into a statistic which we learned in med school, and I don't know if they've modified it, but about 87% of strokes are called ischemic strokes, which are caused by a clot in the artery.
Right.
13% are hemorrhagic.
That's my stroke. Yep.
Right. And of those 13% hemorrhagic strokes, it's divided half and half between subarachnoid hemorrhage, which happens from an aneurysm like your son, and half happens from bleeding inside the brain like your
mine.
stroke.
And Dr. Parker, Professor Parker, is the one that had your son had a...
Right. So the aneurysm strokes are the ones which have the risk factors of smoking, family history, alcohol. The intracranial hemorrhage one typically happens either from blood pressure, alcohol, diabetes, and ever so rarely from lesions called cavernomas. Yours could be one of those. And then the other 87%, only about 15 to 20% of them are considered cryptogenic stroke, which is basically a description which means that we don't know why the stroke happened. And there's a lot of work which is being currently done in this, where people have realized in the last 4 to 5 years by advanced technologies that at least 25% of these are probably coming from the heart. So 25% of the 20% of the 87%. But the idea being about 7 to 10% of these strokes still come from the heart, and you just have to pick a weird rhythm in order to figure that out.
Now, that's interesting that you say that, because at the time that we're taping this, recent news just a couple days ago is that one of the Osmond brothers just had a stroke, and I don't think it was his first one. I think he had a few of them. But through reading the story, a number of the brothers in the family and family members all had some kind of a heart defect. And they say that that's what contributed to his first stroke that he had, from now that I'm kind of recalling the story, and I'm not going to say too much about it because I don't remember all the details about it, but I do remember hearing that there was a family history of having some kind of a heart situation that then brought on the stroke that he had, as well as some of the other family members. And so you hear that there's a tie-in between heart and stroke. But it's interesting in the way that you just put it, how it can really play a major role.
Right. If you look at any of the diagrams of the heart and the brain and how the supply is, the first arteries that come out of the heart go to the brain. So if a clot forms in the heart, and there are very many reasons why clots form in the heart. The commonest reason is AFib, which is 90% of the strokes that we know, but there are 10% other reasons, some of them even being congenital heart disease or septal defects and other situations where you can have clot coming from the veins of the legs into the heart. So there are different reasons why that can happen, and we're discovering more and more over time. And what we've also realized is that it does not matter whether your heart is functioning abnormally all the time. It just has to function abnormally for a certain amount of time, and it can form a clot and send it to your brain.
And how long is that certain amount of time?
Most of the research around this has shown that if you have a 2 to 3 day period of abnormal rhythms in your heart, and the blood is sort of collecting, then it will form clots and send it to your brain.
Now, if it's kind of beating funky like that for a couple of days, is it absolutely going to cause a stroke?
No, that's the fortunate thing. Although AFib causes stroke, or even dysrhythmias cause stroke, most of them are really small, and your body has its own mechanisms to dilute those strokes very quickly. It's
so
only
the strokes or the clot?
The clots, sorry,
okay.
Dilute the clot very quickly. But there's some situations where if the clot has become really thick, then it really does not dissolve automatically, and that's where our awesome Dr. Darflinger swoops in and takes that clot out. If you get to him in time.
You get the plumber.
That's right, we're the plumbers. I just wanted to add, to kind of reiterate, we're talking about atrial fibrillation, and since we're here in Burbank, half of all of our entirety of strokes are from patients that have atrial fibrillation. And a lot of those patients don't know it before they have it. They didn't know that they had atrial fibrillation, but even some of those patients have had these strokes because of the atrial fibrillation. And the difficulty is the medications that we use to treat this are not always easy to take. Sometimes they end up having to change your diet. There's a couple different medications that we use, but to kind of reiterate how we prevent more strokes from happening, you have to stick to those medications even when they're sometimes not as fun to take.
Okay, now wait, you said a lot of stuff here. So now, first of all, you said 50% of all of the strokes that you go in and rotor-rooter and plumb out.
In Burbank, 50% of the strokes in the Burbank area are from atrial fibrillation. And so atrial fibrillation it's an irregular, you have 4 different chambers in your heart, and the signals that go through the tissue help contract those different chambers in a coordinated fashion to get blood flowing through them. And you can have a period of time where you don't have that normal rhythm and the normal contraction of those chambers, and so the blood that's in one of those chambers, it can just remain kind of stagnant, and when blood is stagnant, it forms a clot. And then what tends to happen is you do get a normal beat, you get a normal rhythm, and you get a normal heartbeat. That squeezes as it should do, but now there's clot within one of those chambers that gets sent somewhere else.
How long does it take? What kind of time is the atrial fibrillation?
So if I'm understanding your question, you're asking how long do you have to have that abnormal rhythm in your heart in order to develop the clots? Right. Well, I think my great partner over there, much smarter than me, was talking about some of the literature where we think it could be within a couple days, but the bottom line is it's not something that we can predict. We're all a little bit different in our ability. We're all kind of in this. We exist in this equilibrium where the proteins in our blood are in a balance between clotting and breaking up clots, right? So if you get a cut on your arm, you want to be able to clot, but you don't want to bleed out. So it's your blood clotting factor. That certainly can play a role in having strokes. People who have abnormal, what we call coagulopathies, where they're either not clotting enough or clotting too much, that can certainly have a risk factor for it as well. Now,
you made a statistic assessment of strokes in Burbank, and I know you go to other cities as well. So just so that I'm kind of understanding, it's not like it's something in the water in Burbank necessarily, or something like that.
I think a lot of it has to do with the populations, the age of populations in the particular area. I think I don't know exactly why in Burbank that's the statistic, but we recently were doing some presentations with the fire department and gathered some data, and that's the information that we gathered of our strokes.
That 50% of the strokes that happen in Burbank are all as a result of AFib.
That's correct.
Amazing.
And the treatment for that, we once we treat the stroke and it's safe, we put patients on, there's a couple different types, but it's a blood thinner to help prevent the clotting.
Right. Now, but you were saying that there are some meds that are tough, and it's because it's tough for people to take, it's tough for people to tolerate, or?
Some of them are. So the oldest and Dr. Tiwari, please jump in here, have as much more experience at this than me, but the older and probably the best studied medication, the one we've been using for the longest period of time, is a medication called Coumadin or warfarin. And that has a very narrow therapeutic window, meaning when we start that medication on people, we continue to test their blood to see whether they're therapeutic. And the problem is it's a narrow window. If they're not in that window, if they're too low, it's not doing them any good. It's not actually preventing the clotting.
Yeah, what do you mean by window? Window.
It's a measurement that we take of the blood, and patients that start taking this medication start on a low dose, and we continue to measure their blood to see how quick the blood is clotting. And we measure that in a time ratio, and we measure their time with their blood compared against what we call the INR, the International Normal Ratio. And that window is pretty tight. If it's too high, meaning if your blood is not clotting at all, then you're at a very high risk of bleeding, right? And if it's too low, it means that you're not being anticoagulated. Your blood is not thinned enough, and so you have that continued risk of having more clots in your heart.
And to Rob's point, Coumadin is an old drug. It was discovered in the 40s. It was actually what people used to use for rat poison. Warfarin was a rat poison, and what it does is it kills rats by basically thinning down their blood. But the idea is that it's about, if you look at the number of people who actually stay in that narrow range where it works, it's pretty low. It's about 25%, if I remember correctly. So that's why in 2011 or 2012, some new disease drugs were developed, which were called, a bit earlier than that, which are called new oral anticoagulants. Eliquis is one of them. And these agents have lower risk of bleeding in the brain. But they have about equal amount of efficacy in preventing strokes. Now, don't get me wrong, Coumadin has a really, really good history. We've known the drug for close to about 70 years, so we know what to expect from it. But it's a very, very difficult drug to manage. You cannot eat spinach, you cannot eat certain kinds of vegetables, you cannot eat certain kind of grains. You have to have the same kind of food every day in order to stay in the right numbers. And even then, if let's say something changes in your metabolism, it just goes up and down. And if it goes up, then you can bleed in the brain. If it goes down, you can have clots in the brain. And there are a lot of cases like these. So
maybe these are things that if somebody is on Coumadin, they should bring up to their doctor and discuss, or?
So personally speaking, we have, now, it's not like you can go off Coumadin in every case. There's only one indication where you can go off Coumadin, which is called non-valvular AFib, which is the one that we deal with most often. But there are a bunch of other diseases where, let's say, you have clotting disorders, which thicken your blood, so you can only use Coumadin. So there are a lot of things where you cannot use anything else. But if you have non-valvular atrial fibrillation, then you should definitely ask your physician about other drugs.
And that's the important thing, everybody. As we say at the beginning and the end of the show, take note of all of this, but don't make any changes to any of your medical routine at all without discussing it with your doctor and things like that. So just, be sure of that. One of the other things that I kind of want to turn the corner here before we go to our next break. And you had mentioned something before we went on the air, which was really amazing. And it was about delayed strokes.
Right. So, not to diss all the chiropractors out there, but sometimes when you have motor vehicle accidents or you have like football injuries, our necks are really supple, and they're supple so that we can move our head around and look at 360-degree views. But what happens is that the arteries which travel inside our neck are very vulnerable to this sudden movement. So head jerks. So any of these injuries, like whiplash injury during driving or football injuries, or even the old chiropractic maneuver where they used to crack your neck, or even if you're like working as a carpenter and you keep your head up and move around in that position a lot, what it does is it basically causes the artery to tear on itself. And that tear can be unnoticed. I mean, you might feel a pain in the neck. A lot of people feel that. You might just think it's muscle pain, but what happens is once that artery tears, it starts forming clots, and it can prevent, clots may not form right away, but if something changes in the long run, you can develop a stroke even years later.
Yeah, no, that's something you were talking about, that there was something you gave an example of that was literally years later, but could still be traced back to that particular incident.
Right. So when Rob and I do these procedures, what happens is that we actually look at these arteries, and when we look at these arteries, we can predict what caused the stroke. And there was a gentleman, like our friend Mason, who was a stroke, who's a stroke PA, physician assistant, and he developed a stroke. He was flown down to our system because nobody could figure out what to do with him. He was only 51, and when we went through his history, we realized he had a skiing accident 17 years ago and probably developed a tear in the artery from that. And 17 years later, something in his physiology changed, and that caused the clot to start forming.
That's amazing. Just amazing. People, sometimes you'll see people that like to crack their necks, like kind of stick their hand on their chin and kind of give their head a good crank.
I would say that treat your neck like it's a very, very special part of your body. ideally you shouldn't crack your neck at all because you have no idea how sensitive that artery is. And if you study anatomy and see how that artery sits in the back
where
of
is
your
this artery that you speak of?
So if you run down your fingers down your neck, you know where the two gutters that you feel at the back, that's where the artery travels inside the bone. So when you press hard, you feel the bone, right?
Right.
And you press really hard, you feel like a bit of a pinch, like you almost as if you're pressing on the nerve. Right behind that is the artery. So imagine if you're cracking, how close you are to that artery, and that can easily cause the artery to
Pinch or
dissect.
something, sure.
Right, and that's why like even small injuries like whiplash injury or like injuries on the field, like soccer field and stuff, can cause really major damage later.
Wow. Well, we've got so much more to talk about. We're going to take a break and we'll be right back. Hey everybody, welcome back to Life After Stroke. I'm Christopher Ewing, and as is always the case, whenever we take a commercial break, there are a million questions. We've got a whole bunch of questions here in queue. One is kind of a pickup from where we left off before the break, which was and this isn't to pick on chiropractors, but you and Dr. Darflinger were both saying that you've seen a tremendous amount of young patients that come in from a chiropractor with stroke situations, like a lot of young patients.
Right. And from I have spoken to a few chiropractors who are kind of on the younger side, and they have sort of changed their practice to accommodate that perspective. But there's still a few people who will go to a chiropractor because they have neck pain, and the neck pain is typically because you got a pinched nerve, or you have like too much stress, or you have like you keep your neck muscles a certain way, and they'll go to a chiropractor, and the chiropractor will crack their neck. Some people go to their family members and they'll crack their neck, and afterwards they will not realize that they might have dissected the artery, which can probably have a stroke in like 2 to 3 days, or can have a stroke a few weeks later.
Now, when you say that you've spoken to a chiropractor about changing their practice or their methods, what is the method that they're doing that kind of lends itself to this stroke potential?
So most people who, if you talk to modern chiropractors, they would tell you that they tend to stay away from the neck. Most of the technology of fixing neck pain has moved towards figuring out why the neck pain is happening, as opposed to just causing symptomatic relief. Most of the times, if your chiropractor is telling you that the way they crack your neck will not cause a stroke, is probably not a good idea. That anything to do with your neck, even having car accidents is not really a good idea. So,
do you know what some of these chiropractors are doing that causes it? Is there a particular twist? Is there a particular method that you know that they're doing?
So it's very similar to cracking your own neck. Anytime you twist the head over your neck in any direction, either you kind of tilt it too quickly, or you move it, like rotate it over the neck too quickly, causes the artery to move on itself. Every time the artery moves on itself, the artery is fixed to the bone in the neck, but it's free when it goes into your brain. Because one part is free and one part is fixed. The free part moves faster than the fixed part, and any kind of movement which basically allows the free part to move faster causes the dissection or the tear in the artery.
And what is a dissection, just in kind of lay terms?
So think of it as you have a pipe inside a pipe. That's how your arteries are. There are like 3-4 different pipes, so different layers of pipes, and one of the pipe kind of is what keeps the blood flow going to your brain, and the other one is what keeps the artery sort of pumping the blood up. And what happens is that when one part is moving and other part is fixed, the inner part moves faster and the outer part stays fixed. So a gap develops between them. Basically, the inner tube has moved, but the outer tube hasn't, and that is what a dissection is.
Separation.
Right. Think of it as a Velcro, where you've moved the inner part or one part of it, but you've kept the other part fixed.
I see.
And that's where the clots form. It's between that cavity between the inside and the outside.
And so you were talking about how, and Dr. Darflinger has even mentioned this, that you guys are seeing younger and younger stroke survivors, or even stroke patients. Some survive, I guess, maybe some aren't so fortunate, but you're seeing stroke happen younger and younger. And I know that before we went on the air today, you guys had even mentioned that you had some young ones recently, 29, 30 years old or something like that.
When you look at the scientific data or scientific literature behind this, that's the common term that we use for all the papers that we study. There is a sort of a watershed, which is 45 and below is considered a young stroke. And these people have different risk factors. Some of these risk factors are not understood really well, and it's possible that some of the increase that we're seeing recently is because of lifestyle related things for these for the younger people. Some of it I also think is because we're picking them up faster and they're coming to us faster. So there's something in medicine which is very common, which is called observer bias, which happens that because we're seeing it more does not mean that it's happening more. It's just that because we're seeing it more.
I see.
And that's because there's so much recognition of the problem that the people get to us faster. But that said, there are definitely lifestyle issues out there which are if you have a family history, if you have bad diet, you have bad habits like smoking and alcohol, or you have injuries that you've not noticed, like neck injuries, then they accumulate over time, or even like heart problems. Like one of the biggest young stroke population I see is young women who are on birth control pills, and they have like a hole in the heart and it ends up going into the brain. So there are these very specific causes of young strokes.
Boy. Professor, you had a comment that you wanted to make.
I had my stroke 9 years ago. I have been on warfarin, Coumadin, and Xarelto. I think the Xarelto is the best because I don't have to go into the doctor's office once a month. That's for me a good plus.
Yeah, but you were saying that the drug has also caused some bruising.
Oh, yes. The drug has also caused some bruising, and I think it's permanent now, particularly on my right leg.
So, Doc, is that kind of what you were talking about, how sometimes the drugs that you have to give kind of aren't?
Yeah, there's side effects to these drugs. They're very difficult to take. The bruising is probably the most common thing that we see, and oftentimes when we to kind of take it to another extreme, when we have some of our aging patient population that would need to be on Coumadin, we often have to take a look at how well they are at just walking and how their balance is, and see what their risk factors are to cause themselves injuries, which would be exacerbated by being on the Coumadin. So, for example, my grandmother, I can tell you, she's had AFib and has had some strokes, but now because she's not very well balanced and she has continued to fall, eventually you sometimes just have to say, well, we can't have you take this medication. And now you're, instead of the risk of bleeding, you're at the risk of stroke again.
Sure.
So that's definitely a very, what makes some of these medications difficult.
I am 81.
Well, you don't look it. You look much younger than...
You're not 81, Professor. You are not.
Oh, yes.
Oh, my goodness.
Much younger.
It's like a baby.
Much younger.
You definitely are.
That's it. We're going to video instantly.
26.
I've been threatening to put this... I've been threatening to put this show on video, and now I'm going to do it for sure, because I think every week there's somebody here telling me some crazy age, and it's like, what? No way. Well, I should look that good at 81.
So, am I too old to have the Xarelto?
Well, and let me say this. Now, you raise an interesting point, because it seems like there would be drugs that are better suited for a certain age and some drugs that are not good for a certain age, even though that drug is excellent for stroke across the board. Some of these drugs, I guess my point is that are very age specific in some cases. Is that kind of?
So there is some scientific literature, especially with Coumadin, but also all of these new drugs, the ones which I call the direct oral anticoagulant agents, like Xarelto, Eliquis, and Pradaxa. It's interesting, even Coumadin, as you get older, you're not that old, I meant like 90 plus, they increase your chances of bleeding more, which is why most of these other drugs like Eliquis and Xarelto, you end up going at a lower amount. Most of the times, age is not enough by itself. There's something else like weight. If you're less than 60, or if your kidneys are not working, but most of these drugs are metabolized by the kidney or excreted or like removed from the body by the kidney. So sometimes if your kidneys are not in a good shape, you would tend to be on the lower dose. But most of the times, age is less important than taking the medication.
So I guess what I was thinking is that isn't it interesting how there'll be a drug that will be great for a stroke survivor, but you also have to take into consideration their mobility, their surroundings, their lifestyle, and so forth, and that may have a say in terms of what drug might be good for them or not. Like if you're a fall risk, then that drug might not be great, but this one would be. Not that this drug is going to cause you to fall, but if you do fall, this drug might kind of be a little adverse.
So it's interesting that you've pointed that, because there's a very significant study which came out last year, or maybe 2 years ago, about this, where they realized that even patients who are at high risk of fall are at a higher risk of having a stroke, and therefore should be on these medications, because the stroke has a higher chance of killing them than having a fall and bleeding. Now, in respect of that, because the bruising is higher, people are recommended to go on like medications like Xarelto and Eliquis, because they have lower bleeding rates. Not all bleeding rates are equal, but almost all of them have lower bleeding rates in the brain. So a lot of times when somebody is a high fall risk, and Rob and I have treated patients who are 90 plus, 95 plus, where I have almost always put them on Eliquis, because I think having the risk of a second stroke and significant disability is way more than the risk of a fall. I know someone who has had 4 falls and not bled in their brain even once. So.
Wow, that's really interesting. One of the other things that we have on the list to talk about here is something that you were mentioning earlier, which is family history of stroke. And talk a little bit about that.
So most of the times people have family history of aneurysms is one of the biggest things. If you have if there's one person in the family who has aneurysms, then your chances go up. If you have 2, then your chances are like really high, almost 10%. You have if you have a family history of young strokes, that means that you probably have a poorly understood mechanism of your arteries getting old faster than the rest of your body. So, if people have family history of strokes, any kind of strokes, but more so the hemorrhagic kind, which means that there's something up within your genetics, or even if your parents were living okay, or your aunt or your uncle were not smokers and alcoholics, and they had a stroke at a young age, then that's something which should sensitize you to your increased risk.
And we've got a question over here.
My question was pertaining to the doctor speaking about if you're on a certain medication, you shouldn't eat spinach. My mother's not on warfarin or Coumadin or anything, but are there certain foods that we should be avoiding in her diet, or things that we should be incorporating that would, I don't know, maybe help with the arterial health or just overall health to stave off this, reoccurrence?
That's a very good and interesting question, because while the medication which is typically known to be notorious with the kind of food that you can eat is warfarin, and there's a lot you cannot eat. And people have to be very cognizant of all the things that you cannot do on Coumadin. So if you are on Coumadin, you have to be very, very diligent with the stuff that you eat. But on the other, these new medications, they don't have any dietary restrictions. However, there's some stuff which we've known for years, which are known to sort of make things worse in terms of your arterial health. So processed food like carbohydrates and sugar, not that you have to completely cut it out, but having excess of it in any way has been associated with increased risk of cardiovascular or even vascular problems, strokes, and even cancer. There are some things that have been shown to improve your health. Fruits and vegetables are very good for your arteries because they release antioxidants. Outside of that, ancient whole grains have a lot of fiber in it, so they help improve your arteries. But one of the biggest things that a lot of people know is wine, red wine. And except for a medication which lowers your cholesterol, red wine is the best known agent after exercise to lower your bad cholesterol and increase your good cholesterol. Of course, in moderation. I mean, you're not supposed to polish off a bottle at the end of the day, but one glass of red wine daily or every other day is considered very helpful for a certain kind of product which produces good cholesterol in your body.
Doctor, this is all so interesting. We're going to take a quick break and we'll be right back. Sit tight, everybody. Hey, this is Christopher Ewing with a Life After Stroke health tip. Now, you always hear people ask the question, how did we ever live without cell phones? Well, today, our cell phones can actually help us live. Whether your cell phone is an iPhone or an Android phone, if you have a previous medical condition, and especially if you're a stroke survivor, then you absolutely want to have a medical ID on your cell phone. Now, a medical ID is a special link that sits right on the home screen of your cell phone, where someone like an ambulance driver or a doctor or any first responder to any medical emergency that you may be having can find the important medical information that you want someone to know if you're not able to tell them yourself. Maybe because you've lost consciousness, or you're having another stroke, or maybe you're just unable to speak or remember the information for whatever reason. All someone needs to do if you're having an emergency is click on the medical ID link on your phone, and there they can see all the important information that you've listed there, like your name, any prior medical condition that you may have, any medications that you may be taking, as well as the phone number of the person who should be notified if you're having a medical emergency. Now, on most phones, the Medical ID app is already on your phone and ready to be set up. And if you don't see a Medical ID app currently on your phone, then all you have to do is go to Google Play or the iPhone App Store and download any Medical ID app that you choose. And best of all, most of the Medical ID apps you can choose from are free. So having a Medical ID link on your phone is super important to have. And what's even cooler is, in an emergency, the first responder can even access your Medical ID info, even if your cell phone is locked and requires a password to open it. If you need more information on where to find a Medical ID app and learn how to activate it on your phone, or if you have a really cool health tip that you'd like to share with others, just go to our website, www.thestrokechannel.tv. I'm Christopher Ewing, and this has been a Life After Stroke health tip. Hey everybody, welcome back to the show. This is Life After Stroke. I'm Christopher Ewing, and once again during the breaks, this is where questions start coming up, and we were talking about Miss Wanda's condition that she had mentioned earlier that she had suffered with prior to her mom's stroke. What was the name of it again, Miss Wanda?
Stevens-Johnson syndrome.
Stevens-Johnson syndrome.
Uh-huh.
And I had asked Dr. Darflinger, what the heck is that? And it's amazing, that it's basically an allergic reaction where two or more drugs just don't play nicely together. Is that pretty much what it's about?
Yeah, I'll start by saying this is way out of my field.
No, I get it. I mean, I'm not holding you to it, but
it is a reaction of your body to either a drug or a combination of drugs. And there's some drugs that we have listed that can cause this, but you can, most people can take these drugs and never have a problem. And then for some just very unfortunate reason when somebody has either that drug or the combination, they have this Stevens-Johnson's or toxic epidermal necrosis.
And, Wanda just shared with us just the most amazing, just unbelievable experience that she had through this and what it caused. And really her recovery is remarkable in and of itself. I mean, it's amazing how well she's recovered. You would never even know, but, Google it and you'll see just what this terrible, terrible, condition can do. But the reason why I'm bringing this up is a drug question. I've often wondered, is there any medical body in the world that tests one drug with another drug with another drug and then sits and looks and sees what happens? And then, because, since my stroke, I'm taking like 3 medications. And whoever figured out whether these drugs can go together and play nicely together? I mean, when you're putting all these drugs in your body, who's to say that this plus that will play nice in the sandbox together? Maybe they'll start fighting, which sounds like that's what this is, this Stevens thing. And do they test these drugs together?
So there is a very rigorous process that the FDA does in order to see if what you talking about is called drug-drug interaction. And most of the times what the FDA does is there's several levels of trials which are done, and the initial level is just in the lab, the next level is on animal testing, next level is on healthy patients called phase 3, and then it's introduced as to a small group of community of diseased patients, where they try to study if certain drugs have side effects and if those side effects are more based on working with each other. Like Coumadin is one of the drugs which has a lot of interactions, because most of the drugs are metabolized by your liver. And what happens when they're being metabolized by your liver is that if there's another drug which is metabolized by the same enzyme in the liver, and it goes through the same enzyme, so imagine now you have like one thing which is saturated with 2 different drugs, and that will affect each other's activity. So this is tested in the lab as well as on healthy subjects, but there's another body of work which has recently started coming out in the last 2-3 years, and this has to do with a much more advanced level of analytics, where what you do is, for example, Eliquis is a medication which we spoke about, which is for AFib, and when you're only on 4 to 5 medications with Eliquis, you don't have side effects, but when you go up to 9 medications, Eliquis starts behaving like Coumadin. One of my personal passions is to reduce the number of medications people are on, so that these unpredictable responses don't happen. But that's a new body of work that's going on. It's called pharmacogenetics, where you kind of study different interactions with your genes and stuff. So
because if you're given a drug for, let's say, your heart, and they test it up the wazoo and say, yep, this is safe to take, okay, great. Well, then all of a sudden you develop a kidney problem, and they put you on a kidney drug, and they say, okay, that kidney drug, yep, that kidney drug is great for kidneys and helping people with kidneys, but have they tested the kidney drug with the heart drug to see if they played nicely together? And if you insert stroke and you insert all these other things, all these new drugs that are coming out, you're just putting more and more kids on the playground. Who's to say that they're all going to get along with each other?
So it's an interesting question in the sense that we spend almost an entire year in our medical school studying about drugs and how they might have similar interactions and they will interfere. And every time we try to start you on medications, you'll often see your physician looking up something. Most of the time what they're looking up is if it's going to interact with any of the medications you're already on. So there's definitely a lot of information about this. And even if you Google any medication that you're being put on, it will talk about all the medications you cannot take it with. Sometimes you can, but you just have to be careful that the effect is going to be more or less. So, but what I'm talking about is a different issue, and you're sort of touching on that, is where if you get to a certain number, can you necessarily predict everything? And I think we're just beginning to look at that, and probably in the next few years we'll have more information about it.
I mean, it's just amazing, and what Miss Wanda shared with us over here, man. I mean, I could only imagine if you've got a stroke, let's say, and they put you on a bunch of drugs, and all of a sudden there's one that doesn't play nice with the 2 others, and you go through what she just described to us. us during the break. Count me out. And I just applaud you, and I applaud your recovery, Wanda. Oh my goodness. Just, gosh, amazing. One other thing that you wanted to touch upon is post-stroke pain and how painful that is, because Lord knows I can speak on that. I'm in the amen corner there. And I think who else? I think, Dave, you said you had some post-stroke pain that you were going through too as well. Headaches, absolutely. And I've had those just in the past few days. What in the world is the deal with post-stroke pain?
Post-stroke pain is an interesting entity. What happens is that the way our nerves work is pain is basically a mechanism of our body to tell us that we need to get away from something. If you're burning, if there's fire next to you, if you don't get the sensation, you will not be able to prevent yourself from burning. So pain is body's way of telling itself that get away from this. Now, all these sensory organs in your skin go and connect in the brain, and then they relay the information to a part of your brain which decides what to do with that signal. So when you feel the pain, that part decides what to do with the signal. Sometimes what happens in a stroke is that this system gets scrambled. So even though you're not perceiving pain, the system starts acting as if it is perceiving pain.
So even though there's no reason for you to say ouch, like you didn't hit your toe on the coffee table or something like that,
right,
it's still going to feel as if you did.
Right. And that's why it's such a difficult problem to fix, because, if you hit yourself on a coffee table, how do you avoid it? By not hitting yourself.
Right.
But if it's coming from your brain, if it's an abnormal signal which is originating in your brain, then it's very difficult to fix it. And most of the times, the way it's perceived, it's called nerve pain. And that is typically one of the worst kind of pains people can feel. There's a certain part in the brain called the thalamus where it's localized mostly, but anywhere along the sensory pathway which is responsible for pain perception, a stroke in that area or a lesion in that area can trigger this problem. And what ends up happening, and a lot of people who have like even limb injury or spinal cord injury, if let's say you have an amputee, they may lose their limb, but they don't lose
phantom pain.
Right. So it's a similar mechanism. The idea being that the representation has not gone away in your brain, even though the limb is missing. So sometimes the signal gets scrambled and it starts acting out. And we don't really have a lot of good medications for that, because the only way to dull down that kind of signal is to dull down the entire brain.
Right.
Which means that you would become very, very sleepy. And there's some cases where people have used very, very high doses to take care of that kind of pain, just to allow it to be fit again. I live with it 24/7, and I'm in pain now, but it's like a 2 or a 3 because I'm just kind of sitting here chilled in the chair. But it can go easily up to a 9. Every night, sometimes sleep is terrible, tingling. Sometimes it feels like my arm is on fire. And if I'm in the shower, just water droplets could send me through the roof, and it's just amazing. And I've said a couple shows ago just how weird stroke is. Right. I equated it like a tornado that hits a town. It might fly into the town. One house might get totally wiped out. Another house might just lose its roof. Another house might be, the tree fell in the garage. Another house might be standing perfectly still. And they might all be right next to each other. People will see me and be like, well, it doesn't look like you had a stroke, but, right after I had my stroke, I didn't nearly talk as much as I do now, Lord knows. I said like 2 and 3 words, for weeks. But my point is that what I'm left with post-stroke is this incredible post-stroke pain and the tingling and the numbness and like sometimes it feels like my arm's on fire and stuff like that. But yet I've talked to some people that have had a stroke that said, I never had any pain. But it's just so weird. It's just all so weird. Right. And it depends on where you have the stroke. Most people will have a stroke in part of most strokes take away your sensation. They actually don't give you extra sensation. But if you happen to scramble one of the areas that process pain, and
mine was in the basal ganglia.
Right. So the deeper nuclei of the brain, basal ganglia being one, thalamus being one, have all these connections that we don't really understand so well. So a lot of times people will develop symptoms that we can't always predict, and that's why it's so difficult to fix it, because we don't understand the process so well.
Yeah, and the thing that I've understood is that that's why it's also difficult to get on medication, because it's not really an injury of sorts. It's just your brain telling you that something hurts, but it doesn't. You look at it, it just looks like you know, you don't see a scar, you don't see a bruise. It's because nothing happened to it. It's just really in your head that's telling you that.
Right. I mean, think of it like, you know, as if your computer's developed a problem on the inside, like a virus, and you just have to wipe out the whole thing, except you just can't wipe out the signal in your brain.
Yeah, right. Exactly. And there's nothing you can put an ice pack on, because there's nothing to put an ice pack on, because there's nothing that's swollen. It's just this signal in your brain that says, hey, this is going to hurt, you know.
There's been some work which is being done on this. I don't know how well it has progressed, but there may be in the next few years a different kind of future to fixing this kind of pain. A lot of work has been done, but pain is unfortunately one of the most difficult things to fix, because it has too many different areas where the signals go.
When I Googled this, I started to find that a lot of pain, this is certainly the case with me, centers in the shoulders. Why is there such a high incidence of pain in shoulders post-stroke?
So typically what happens is that before you have a stroke, or when you have normal stuff, all the nerves which go to your muscles kind of keep your muscles in a certain position. And that position is best for your joints, because it doesn't kind of cause your joints to sort of get misarticulated or not work together well. When you develop a stroke, some of these nerves stop working. So your muscles start getting lax and the joints start moving away from each other, and you go into positions which you're not typically supposed to have, and that starts causing muscle fatigue and muscle pain. So most of that is sort of musculoskeletal. There is some incidence, especially in the back of the brain, where a stroke can cause nerve pain in the shoulder and the neck. But like I said, I mean, pain in stroke has so many different causes that each one of them has to be independently seen.
Is there something you can do? Obviously not medicinally, it was, as we've discussed, exercises.
So rehab, one of the things that it specifically focuses on are these abnormal muscle movements and these abnormal joint positions, there's definitely something that can be done for the musculoskeletal pain. You can do Botox. There's some new technologies which have been developed. One of them we were experimenting at NYU called hyaluronidase, which can fix how these group of muscles and joints and bones interact. But it's still work in progress, and I can't say that we have a conclusive answer yet.
Miss Helen, you had a question.
How long will it take me to get over having this stroke?
Good question. How long ago was your stroke, Miss Helen?
In July of 2013.
So stroke recovery is an extremely complex topic, and what we understand about stroke recovery is mostly motor recovery, which means that when you lose movement, how quickly you recover movement. And most of the stuff that people tell you has to do with, when people talk about 3 months or 6 months, it actually has to do with the research which has only been done on movement. It does not deal with speech. There's evidence out there that speech can recover up to 2 years, if not more. This year at the International Stroke Conference, they're going to talk about this new mechanism that the brain heals itself, called pericytes, where these sort of stem cells migrate and try to fix some of the problems. So another thing that we were working on once again in New York was called mirror neurons. A lot of people have been working on it, and that might be the reason why Tai Chi helped you, is that there are certain movements where if you move one arm in one direction, the paralyzed arm perceives movement. So you can actually fix movement of the paralyzed arm by moving the normal arm. And that might be something which Tai Chi or yoga may be doing, is it's inducing these mirror neurons which help you in recovery. What we know, or we think we know, I'm going to put that cautionary tale out there, is that the recovery is fastest initially and then slows down over a period of time.
Why does that happen?
I think it actually has to do with how the brain heals itself. in the first month you might not notice any significant recovery, but after that, when you have a stroke, there's a lot of fog, so there's a lot of swelling and there's a lot of pressure on normal tissue. But once the pressure goes away, the tissue which is around that damaged tissue starts taking over that function. And if you it's sort of in that phase where like you're getting these stem cells working and these other mirror neurons working, where if you try to train them very quickly, you can learn a lot, and that's why the recovery seems to be faster early on. However, there are other people who argue against, like they talk about episodic challenges in order to have more recovery later. I don't think it's been completely figured out as to what exactly is the timeline. It's just that what we know so far is that the first 2-3 months, if you give a lot of challenges, and that's why you get rehab and all the other things, you may end up inducing the other brain tissue to take over some of the damaged brain tissue's function.
Well, that's really interesting. Ms. Helen, you had another question.
My assumption is that when they have physical therapists come to your home, they teach you maybe to walk, to lean, but they don't delve into the incline you're going down or up. Why is that?
So you mean from like a confidence standpoint or balance or?
Balance.
Balance. So what can a stroke survivor do when they're in the process of their recovery and overcoming some of the deficits that they may have as a result of their stroke, and kind of regain the confidence of walking, climbing stairs, balance and things like that?
So there was a very interesting talk about a couple of years ago by this professor of rehabilitation from Johns Hopkins, who showed that the thing that actually improves your recovery is the number of times you do that movement. It's not, and this is part of the problem with having a stroke. And it's there's post-stroke depression, there's pain, there's all this stuff that's going on. You are least likely to do more movements rather than you tend to be. So it's sort of like working on math when you're flunking math all the time. It's really that's what it is. It's the number of movements you do in that specific organ, and by doing the incline thing, what they're doing is they're challenging your balance organs to figure out different trajectories for the balancing to work. But that's part of the problem. It's definitely a different talk with our medical system, that you need more and you get less, right? So you actually need way more movement. There was a term that he used that in therapy, you get about 100 movements of your arm when you need 5,000 to actually have that improvement.
I see.
So, but that's the idea, that it's doing more of that movement which helps and not less in early on. Specifically.
But yeah, because of pain and depression, you might not want to do more because it's going to hurt or it's going to bum you out. And so you just be like, so then the chicken and the egg kind of thing starts to... Wow, so amazing. We're at kind of the point in our show where we turn the corner and say to you, final thoughts.
This has been great that I've been able to come and talk about all of these.
It's been great to have you. I don't know who you talking to.
just the fact that a lot of these questions people have, and they don't have people that they can actually ask these questions. So I would definitely say that all these things that we've spoken about, you need to go to somebody who is an expert in stroke, who really treats stroke day in and day out to get your information. It may not be your primary care, even though primary cares are really helpful for hypertension and diabetes, but they might not be the right stroke people for you. There are resources out there from CDC and from American Heart Association, which you can use. You can listen to podcasts like Chris's where you can get this information. But always remember, it's not about how much information you're getting as opposed to the quality of information you're getting. And that, I think, needs to be fixed.
Right. Very true. Well, that's why we do what we do here, Doc. And, and we could never do it without people like you. And so, everybody listening, this is your stroke support group. I mean, while you might not be in the proximity of Burbank, California, when I had my stroke, I couldn't wait to get out of the hospital and put something like this together because I was finding nothing. And I said, you know what, if for no other reason than to just help myself, I need to get some answers as to what the heck just happened here. What was this truck that just hit me, and did somebody get the license plate number of that guy and get him, But, just through coming across people like you and Dr. Darflinger and just all this incredible information and just the wealth of knowledge that all of you have amassed over your adult lives and what you've chosen to do with that adult life just kind of spurred me to want to put together something like this. So for everybody listening, this is your stroke support group, no matter where you are in the world. I hope that talks like this and great guests like Dr. Tiwari are helpful to you. Definitely seek out information in your own area and things like that. And I don't know, Doc, this has just been such a great show. I mean, we've just had such great shows, and I'm not trying to pat myself in the head. Please, I'm just the moderator. I don't know anything, I'm just saying that it's just been so great to be able to have people like you, Dr. Darflinger down here, just shed the insight that you guys have, for us, because we're just learning as we go along, and we don't know what the heck is going on.
And as a physician, I would like to thank you for doing this, because I feel this is amazing work.
So I will.
Oh gosh, this is Dave. No.
This is amazing work. I mean, we need people like you, many more people like you.
Yeah, we need more people like you. Trust me, and Dr. Darflinger. And you guys have heard me say it before, and I am definitely going to say it again. You devoted your lives to helping people like us get our lives back, and you've come into our lives at some of the most traumatic, most terrible points of our lives. And there is nothing more special than when you are at your most helpless that you come across people like yourselves who are so selfless. You could have chosen any job. You've heard me say this before. You did not have to do what you're doing for a living. But for whatever reason, we had to have our strokes. And good on you, and God bless you with the fact that we have been fortunate enough to have people like you along that journey, whether you were the plumber who pulled the cloud out of our head, or whether you're the one who's sitting at this table while I'm rattling on and we're doing this thing here, and you're blessing people all over the world through this. And it's about getting out this information to people who need it in an effort to try to help them. And so I thank you very, very much, very much.
It's a pleasure.
We've been speaking with Dr. Ambooj Tiwari, and everybody listening, I also thank all of you for being with us. As always, remember, there's still a beautiful life after stroke.
This has been a recorded program of an actual stroke support group. The comments expressed are the opinions of the participants, and not necessarily the opinions of the producers, sponsors, or the broadcasters of this show. This program is not to be used as a way to diagnose or treat any medical condition that you may have. Please consult your doctor or healthcare professional before making any changes to your current medical routine.